Alright, so now continuing on, we are finally getting started with block 2 of NBME 24. So, still like the test, it's not that bad. I think it's a fairly more realistic NBME that I've seen. I haven't finished all of it yet, so I'm actually making the explanations and then making the videos as the days go, so you can see like the latter parts of this are not really done. So yeah, it's a pretty painful and slow process, but we'll get there as we get there. Right here, so we can just dive right into it. Let me just combine this real quick. Make it a full screen. Alright, so first thing here, block 2, question number 1. 11-year-old boy is brought to the emergency department by ambulance with his mother 30 minutes after she was unable to awaken him from a nap. The mother states that he was recently diagnosed with type 1 diabetes and she has been having difficulty adjusting his insulin regimen. He's unconscious and his breath smells like acetone. He is responsive only to sharp pain. A rapid test shows a serum glucose concentration greater than 500. So all of this is signs of diabetic ketoacidosis. Which of the following best explains this patient's altered state of consciousness? So you look at all your answer choices, and the only one that should really make sense and strike at you immediately should be answer choice E. It would not have to do anything with an altered affinity of oxygen because of hemoglobin A1C. Hemoglobin A1C is actually able to grab oxygen just as well as normal hemoglobin. Diminished transport of glucose across the blood-brain barrier is pretty illogical. Excess free fatty acids in the CSF don't really make sense either. Inability of neurons to perform glycolysis. No. None of those answer choices really make any sense, nor do they have any basis to them. The patient has diabetic ketoacidosis, which is most commonly seen in diabetes type 1 patients, especially DM1 patients that have missed their insulin. The body starts breaking down fats to increase ketogenesis, which is great for them because it's the only way to make up for the problem. However, the extremely high glucose levels that they have cause severe dehydration and can lead to delirium. Right? So this is very different from what is known as ketosis, something that people do, even I'm doing right now, which is just a form of weight loss and it's just healthy. Right? So ketogenesis versus diabetic ketoacidosis, those are completely different scenarios and not to be mixed up with each other. The extremely high glucose levels need to be managed by giving the patient insulin. And one of the other things you do to treat patients that are going through DKA is to give them IV fluids, right? So osmotic diuresis was the main problem here, and it's not so hard to remember because first aid actually does a pretty good job talking about it all. So right after they discuss type 1 and type 2 diabetes, they jump right into diabetic ketoacidosis, which is one of the key reasons I always recommend come back to first aid while you're doing your UWorld questions, because every time you come back, you'll be able to see things that are related to each other on the same page. And here you can see DKA is deadly. There's delirium, Kussmaul respirations, which is rapid deep breathing, very iconic and classic of them, and then dehydration, right? Dehydration because of all the excess sugar that's in them, causing osmotic diuresis, more potassium loss, and total body potassium depletion. So these labs are often tested, the labs that are right here, right? So you're going to have high glucose in the serum and the urine, low pH, which is why it's in acidosis, low bicarb, high ketones, which is the normal physiologic response to this, and low sodium and a high ammonium, right? So this is also often tested, low sodium and a high ammonium. The potassium thing is a tricky lab thing that's often tested for DKA because everyone's very quick to pick potassium would be low, but it can be normal, right? So the key thing here is that the book tells you osmotic diuresis causes potassium loss in the urine, so there's a total body potassium depletion, but at the bottom I've added some notes from UWorld. It says total body potassium is lost, but extracellular potassium actually remains normal or increased due to excess potassium hydrogen exchanger activity and the lack of insulin, since insulin promotes cellular uptake of potassium, right? The mechanism of action of insulin is actually pretty important too, and understanding how that works is also relevant. So if you ever get a question about potassium levels, first of all, it's very unlikely you'll get a question on the potassium levels of DKA, but chances are they could give you charts that have various potassium levels and you have to figure out which one is related to diabetic ketoacidosis. You can't base it just off of the potassium, so keep that in mind. There is no solid number that the potassium level would be at for a DKA patient. Question number 2 goes on to talk about biostats. So this researcher hypothesizes that exposure to more than 50 micrograms per liter of arsenic in drinking water is associated with an increased risk for development of a common cancer compared with persons whose drinking water contains less than 5 micrograms of arsenic. Which of the following is the most time-efficient experimental design to investigate this hypothesis? Now this question was a little weird. This is, I wrote right here, classic NBME trash, because they really messed up what they're trying to ask here. The question asks for a time-efficient experimental design. However, the answer choices that they've put here are mainly all observational designs, right? These are all observational studies, case control, case series, cohort, open label. Answer choice E is the only experimental study of a clinical trial. That would be an experimental study, and it's very clear to pick answer choice E. You can confidently pick it and be like, I must have gotten it right. But this was actually A. The point they're trying to make is this whole time efficiency aspect and the fact that you're comparing a control versus a case. So the case control here would be that you would compare the case of people drinking high arsenic versus a control, which is people not drinking any arsenic, right? Less than 5. So this is very similar. The main thing you were supposed to see here is that in the question it's very similar to what's happening with cigarettes in our book example in first aid, right? People that smoke cigarettes versus people that don't smoke cigarettes, and then you try to see the association with lung cancers. Now keep in mind, something I stressed a lot yesterday was that there's no causality being established here, so make sure that you don't pick the answer choice that says smoking is definitely causing lung cancer. No, it's relevant. They're definitely related to each other, but no causality. All in all, though, this question is obsolete because the way they asked the question, right? So they should not have said experimental design to investigate this hypothesis. They should have just been an observational design. All right, so that's a very critical thing that, again, NBME is notorious for messing up little things like that because they don't really seem to have the etiquette. They don't actually have the key knowledge. Now, of course, NBME loves asking questions about all of these things. Some of the notes I have are from actually other NBMEs where there were answer choices that were not one of these studies, right? So first aid only mentions the main most popular studies, right? Cross-sectional, case control, cohort, crossover, and then these twin and adoption studies. But there's a bunch of other little sub-studies that fall under these categories already. So like under case control, you have case series. It was on NBME 20. An ecological study was also mentioned in another NBME. So these are all other little things that you don't necessarily have to know, but you should know these guys well enough to knock out these answer choices and then pick something else, right? So when I was doing this NBME, I picked E as my answer for this question because they wanted an experimental design, and you can totally do it by double blinding and having a controlled trial where no one knows what they're actually drinking, but they're drinking it, and then you monitor what's happening to them. But definitely, wording of the question was what got me there. So hopefully not many people fell for that mistake. This one, 43-year-old woman with a 2-year history of labile hypertension comes to the physician for a follow-up exam. Her blood pressure has ranged from 123/84 to 165/112 since being diagnosed. One day after propranolol therapy is started, she develops a severe headache and her blood pressure is 214/132, super high, both systolic and diastolic. Serum and urine catecholamine concentrations are 4 times the upper limit of the reference ranges, and that should be a giveaway for the diagnosis. CT scan is definitely confirming the diagnosis with the 2-centimeter nodule in the right adrenal gland. So the patient has a pheochromocytoma. Which of the following is most likely responsible for the increased blood pressure in this patient after propranolol therapy was started? So now, in real practice, this is extremely rare. This wouldn't really happen. This is something I would imagine would happen in a third world country practice. The patient came in for hypertension and you gave them a beta blocker. Very unreal thing to do. However, this question is kind of testing you on the treatment of a beta blocker. The treatment of a pheochromocytoma. So generally speaking, the way to treat it is to just do the surgery. But pheos are extremely sensitive. Doing that surgery can actually cause a surge of epinephrine and norepinephrine to just leak out and possibly even kill the patient. So you have to give them pre-medication before the surgery. And that takes time too. First, and it goes in ABCD order, first you have to give them an alpha blocker to stop the vasoconstriction that all the epinephrine is causing via alpha-1 receptors. Then you give them a beta blocker to slow down their heart rate, But of course, giving a beta blocker would cause vasoconstriction. So that's what happened to this patient, right? This patient already had alpha 1 induced vasoconstriction, and then you gave them a beta blocker and got rid of any beta 2 related vasodilation that was there, causing even more vasoconstriction. So her blood pressure went up from 165 to 214, and she's going to end up having excessive problems if the treatment isn't initiated and fixed up immediately. That's not so bad at all over there. This one, 4-year-old girl is brought to the physician because of a 6-month history of foul-smelling stools and failure to gain weight appropriately. She's at the 3rd percentile for height and weight. Abdominal examination shows distension. Stool analysis shows an increased fat concentration. Serum concentrations of anti-endomysial and anti-tissue transglutaminase antibodies are found, and that's pretty much diagnostic of what's happening. Which of the following findings in the GIT is most likely cause of the disorder in this patient? So the foul-smelling stools and the failure to gain weight is all because she's having fatty stools. She's losing all her fat and her feces. And the antibodies they found are diagnostic of celiac disease, where all you get in celiac disease is villus atrophy, right? So this is very important, very much discussed in first aid as well. And that villus atrophy, there's a way to check for that, which is using the D-xylose test, right? So D-xylose would passively be absorbed in the proximal small intestine. Blood and urine levels would be low if there are mucosal defects or bacterial overgrowth, right? But it'll be normal in pancreatic insufficiency. So the thing that's happening here is that D-xylose is a glucose it's a kind of sugar that you don't need a pancreatic effort to absorb. So if it is absorbed correctly, then everything's going to be fine. But if it does not get absorbed, then all the D-xylose this patient took would be found again in blood and urine levels, right? So blood and urine levels would be low with mucosal defects or bacterial overgrowth, and that's what's going to happen here. In celiac disease, you have decreased mucosal absorption. The stomach will be perfectly fine, but you can see from the histologic image they gave, you're going to have damage to the villi, right? And that's really all that happens. Celiac disease is a very high-yield topic in step 1, 2. They love bringing up questions where someone might have presented with some of these rashes over here due to the autoantibodies they have, specifically this one, the anti-epidermal transglutaminase, causes a dermatitis herpetiformis. They present like this, and then they're going to try to ask you what else you might find, and you would find the villus atrophy, right? So that's what our question was testing about. When D-xylose does not get absorbed, right, it'll just keep passing in the feces, right? So that's the problem there. So blood and urine levels would be low because it all exited in the feces. If you do absorb it, then you would find it in the blood and you would find it in the urine, and that would be it. Because our body doesn't necessarily use the D-xylose, so you would urinate it out eventually, and that's what's supposed to happen, right? So blood and urine levels would be very low though because you didn't absorb it. Okay? So absorbing it is important. Any D-xylose a patient eats, if it did not get absorbed, it would just come out in the feces. And it's often really hard for many people to understand how the D-xylose test works, so that's the only reason I'm stressing it right now. When you eat D-xylose, if you did not absorb it, it would just come out in your feces. It just went through your intestines, never got absorbed, and then you just pooped it all out. If you did absorb it, it'll be in your blood and it'll be in your urine. The reason it'll be in your urine is because you don't really use D-xylose. Okay, so that's a very important thing to be able to understand right there. So that's all this question was about. The other answer choices here, I listed out what they're related to, and it definitely had nothing to do with this patient's presentation. Number 5, 26-year-old man comes to the physician for a follow-up exam. 1 month ago, his total serum cholesterol concentration was super high, 325, and he was given an HMG-CoA reductase inhibitor, basically a statin. At the time of the present examination, the serum cholesterol concentration is much lower, 235. Which of the following is the most likely cause of the decrease? They're basically asking you how statins work. This same question was already asked in block 1, question number 43, which we went through yesterday. Same exact thing, the mechanism of action, and same exact answer, which is E, increased number of LDL receptors on hepatocytes. That's how they work. So the mechanism of action, just for completeness, I'll revise it again, because the more times you look at it, the better it gets, and the better your chances of recalling it. So statins, what they do is they inhibit the conversion of HMG-CoA to mevalonate, and mevalonate is something that would eventually make more cholesterol. If you don't have cholesterol, your liver puts out more LDL receptors to pick back up any circulating cholesterol. thereby lowering circulating cholesterol levels, and that treats the patient. But this is very hepatotoxic because things are happening in the liver that shouldn't be happening. Your liver will also start making more HMG-CoA in attempts of trying to make more mevalonate, right? So HMG-CoA reductase, the enzyme that's being inhibited, your enzyme is going to produce more of that enzyme, and all of that can become hepatotoxic, right? So very important to make sure you understand how that works and remember this mechanism. This question was okay. The picture they gave isn't exactly the best picture for this microbe. 28-year-old man with AIDS has fever, headache, and lethargy. Examination shows papilledema and nuchal rigidity. A mucicarmine stained image from the CSF is shown. Which of the following is the most likely primary site of infection with this organism? And you look at all your answer choices. In general, the lung is probably going to be, the most likely thing because there are so many bugs that infect lungs. Especially in AIDS patients, so many bugs can cause lung infection, even though it wouldn't cause this lung infection in someone immunocompetent. So lungs were probably the easiest answer choice to pick here anyway, even if you had no idea what was happening. But yeah, this patient, has AIDS. This image shows budding, but it is not broad-based budding. This is narrow budding. And that's arguable because in this picture, you can't really tell. And the reason for this bug, you can't really tell whether it's broad-based budding or narrow budding, is because this is a very heavily encapsulated bug. So the capsule makes it look like it's broad-based budding, but it's not. The reason it's not broad-based budding is because, remember, broad-based budding means that the new guy comes off the old guy with a very broad base, like that, right? Whereas here, there is no broad base. You can't really see a broad connection of a base, okay? All you're seeing that's broadly connected is the capsules. All right, so this is having narrow budding, which is very much like this. All right, so the new guy comes off the old guy like that, and that's all that's going to happen there. So very important to be able to understand that difference. And what was nice in this question is the mention of mucicarmine. So mucicarmine is a giveaway for the crypto that this is. Right, so we go to 178. Right, so this patient, oh, they're at the wrong page. 153, not 178. Let's find it real quick. Right here, right, this thing, cryptococcosis. So I wrote 178, but it's 155. Right, so this stuff right here, crypto. Now they put one answer choice that was there to confuse you, which is, oh, they didn't have it here. No, never mind. If they put any of the brain answer choices, that would be another confusing possible correct answer choice. Meninges would have been the correct answer choice. But yeah, this is just cryptococcus in that question. And you can see all the ways that you're supposed to be able to visualize this bug. It's pretty intense. Right, so images, images G and H, right? So you can see these two right here. The mucicarmine actually stains the capsule, so that's what you're seeing in image J right here. Sorry, H over here. And G is another very popular image, but very easy image to use. G is showing you the India ink clear halo. That's a giveaway for cryptococcus. The only other thing a question can mention is the latex agglutination. Right, this would be another way for you to see. This is the most specific and sensitive test for confirming cryptococcus. It's not a bad question, but definitely doable. Can we assume that all systemic fungi cause lung infection first and then spread to other organs? Pretty much, yes, because it's really easy to cause lung infection. Lung infection doesn't really take much. Other parts of the body have more barriers, so those parts get infected a little more difficultly. With more difficulty. So yeah, you can definitely assume that many of them cause lung infection first. Cryptococcus itself, most likely causes mainly, it doesn't really cause lung infection. It causes the meningeal stuff, but that's not what the question was asking. So the question wasn't really asking where it would cause infection. They were asking most likely primary site of infection, so where it would like start. And since it's something that's inhaled, it would start there, right? Acquired through inhalation with hematogenous dissemination to meninges. And that's what it's more popular for. Cryptococcus is more important for that. You get your soap bubble lesions in the brain, etc., etc. But cryptococcus does have some level of lung infection as well. All right, so soil and pigeon droppings. So really not a hard question just because the answer choices are pretty easy. The image, not exactly the best, but they mentioned mucicarmine. You can see the capsule, so it's doable in that aspect. Number 7, a 68-year-old woman with acute myelogenous leukemia begins treatment with standard induction chemotherapy. After completion of the regimen, her leukocyte count is 1200 millimeters cubed with an absolute neutrophil count of 475 millimeters cubed. So both of those are pretty low numbers. Which of the following is the most appropriate pharmacotherapy? Well, the patient's leukocyte count and neutrophil count are low. She simply needs something that will help her make new white blood cells, and that would be your GM-CSF, granulocyte macrophage colony stimulating factor. AML, acute myelogenous leukemia, or what I call aged men leukemia, is treated with vitamin A and arsenic, especially if it's the APL variant with the T1517 translocation. The problem in AML is that there are high amounts of myeloblast cells that are unable to mature. Right? So vitamin A and arsenic actually induce differentiation and make them mature. Giving GM-CSF will not really mess up the AML treatment, and the patient will be able to recover her white blood cell count. So let's go back and take a quick look at that. 469. Let's fix this right here. So 469, enter. Yeah, this is where you see AML, right? So acute myelogenous leukemia, all the things that are relevant to it. The reason I call it aged men leukemia is because of, one, it does occur in really old people, but other thing is you can remember that aged men use canes to walk, which is going to be relevant to the hour rods that you would find, right? Usually a very difficult thing to see in images. The image they put in first aid clearly shows you a rod, but you'll see on the test, most images that are trying to show you hour rods are not going to do a good job depicting hour rods at all. It's going to be very faint and very difficult to catch, right? So that's your AML right there. And then the other thing, page 121, to look at what our answer choice was. So right here you can see all the different things that would be answer choices. Thrombopoietin was one of the answer choices too, but that's really only relevant for platelets, so that's pretty unnecessary to give to that patient. She didn't have a lack of platelets. You could have GCSF or GM-CSF as answer choices, and it really depends on whether the patient needs monocytes or not. And our patient can use monocytes as well, so you go ahead and give that. All right, nothing crazy, pretty doable. The other answer choices are irrelevant, like interleukin-2 is to make T cells. TGF-beta is irrelevant, and erythropoietin would be for anemia, but she doesn't need red blood cells, as far as we can tell for the question. This one was a 70-year-old man is brought to the emergency department because of a 1-week history of progressive shortness of breath with mild exertion, cough, fatigue, and weakness. The shortness of breath frequently awakens him from sleep and is partly relieved by sitting or standing. He has a 20-year history of hypertension treated with diuretics and ACE inhibitors. However, he does not always take his medications, so that's pretty bad. His pulse is 85 per minute, respirations are 20 per minute, blood pressure is very high, crackles are heard in auscultation. A chest x-ray also shows cardiomegaly, so it looks like a lot of things that are causing left heart failure, and these are all signs of left heart failure, right? In the beginning, they mentioned shortness of breath requiring him to wake up, and sitting or standing, those are all signs of orthopnea. The crackles are a sign of blood backing up from the left atrium into the lungs, right? And then, of course, the cardiomegaly, so all of that is causing pulmonary edema, causing the crackles on auscultation. So what pattern best describes or characterizes his cardiovascular variables at this time? So this is only difficult when you're brand new to studying cardiology, brand new to studying for step 1 and stuff like that. Once you start becoming much more acquainted with all this is heart failure. So if this is heart failure, you're obviously not pumping out a lot of blood. So stroke volume would go down, and if your stroke volume goes down, that's kind of directly related to cardiac output. Cardiac output would also go down. So at that point, you know it's going to be stroke volume goes down, so you cancel out half the answer choices, A, B, C, D. And then if stroke volume goes down, so does cardiac output, you cancel out another half answer choices, leaving you with just F and H, right? Now, what's going to happen at left ventricular end diastolic volume? End diastolic volume means that when you're done filling the heart, how much blood is in there, right? That's the end of diastole. Here, since you didn't pump out much blood to begin with, you actually got some blood left even at the end of systole, and systolic volume would also be a little higher in these patients. At the end of systole, a lot of blood will still be left in the ventricles, and then during diastole, more blood will come into that, so end diastolic volume would be higher than normal, and that's what answer choice F gives you. Okay, nothing insane in that either. This question is another one of those questions that NBME loves to keep asking about. So, a 52-year-old woman comes to the physician because of severe pain in her mid-back for 2 weeks. She has a history of left breast cancer, treated with mastectomy and chemotherapy. Physical exam shows tenderness to palpation over the thoracic spine. An MRI of the back shows metastases in thoracic vertebral bodies. Which of the following veins is the most likely path for tumor cells in the breast to obtain access to the vertebral bodies in this patient? Right? Now, you've never heard of these veins, and you've never seen this if you never did an NBME and reviewed it, because First Aid and Kaplan don't really, no, sorry, not Kaplan. I hate Kaplan. I never use Kaplan. But First Aid and UWorld don't really mention these things, you know. It's not exactly the most high-yield topic either, but at the same time, it's a pretty easy, relevant, and important topic, so it's worth knowing. I've put some pictures here that are relevant to this question, telling you what's happening. The correct answer here was your intercostal, which by logic you could pick even if you didn't know what's happening, because clearly something is going from the breast to the spine, so intercostal would make sense. Is the only thing that's going to come back to the spine. But you know, axillary, internal thoracic, lateral thoracic, and subclavian are all other answer choices that can be plausible to some level based on, you know, what you know and how much you know. In this first picture here, right, we can see the internal thoracic artery and vein right here, right, and then you have your anterior intercostal stuff. Intercostal stuff is all coming back over here, going to the azygos vein, right? So that's what's really happening. So although the internal thoracic might be a part of it, the internal thoracic ultimately brings it to the intercostal vein, and that intercostal vein is going to come back to the azygos vein. Now, continuing on into this image, you can see the azygos vein brings it to something called Batson's plexus, right? Batson's plexus is a vertebral plexus that is ultimately going to be the reason why this cancer was able to metastasize to the spine. The azygos vein also, of course, goes to the supravian cava, and then the rest of it is all flushed out. This image here is just showing you the rest of the veins and arteries that are being mentioned here, and I've explained why the other ones are wrong. Many of the other answer choices are actually just related to each other. For example, answer choice D, your lateral thoracic vein, actually drains into A, which is your axillary vein, which then drains into E, the subclavian vein. And all of that is going to come back to brachiocephalic and go into supravian cava and get dealt with in the heart. So, you know, that's going to be all related to each other. Regardless of all this information, what first aid teaches you and what step 1 is going to ask you about on top of this is also relevant, but UWorld also teaches is that axillary lymph metastasis is the most important prognostic factor for breast cancer, and this occurs by the lateral mammary, right? So the lateral mammary is shown right here, your lateral mammary vein. Okay, this goes into your axillary vein, and that's what allows, remember, lymph and veins kind of flow together, so lymph is going to be going in this vein right here, and that's the path you want to remember, lateral mammary to lateral thoracic to axillary veins. Okay, very important. So that's what's happening in this image right here. This was a very important topic that isn't in first aid at all, so just today I actually copy pasted this question with the explanation like this, and I put it into my annotated first aid. So totally an annotation worth making into your first aid. And if you bought my version, just add it in right there. So, or shoot me an email for the most updated version. But on the next page, I added this into it, so you have a nice little summary of the lesson that you need to learn, which is related to the Batson's plexus. Right, very important topic. It's not in first aid, and I don't think I've ever seen a question about this in UWorld either. Number 10, an 80-year-old woman, so that's extremely old. 80-year-old woman with poorly controlled type 2 diabetes and hypertension comes to the physician for a follow-up examination. She also has a 5-year history of chronic kidney disease with increasing proteinuria and a recent creatinine clearance of 30. Blood pressure is very high. Physical exam shows edema over the lower extremities. Pulmonary and cardiac exams show no abnormalities. Compared with a healthy individual, which of the following sets of lab findings is most likely in this patient? So this is just a question about chronic kidney disease, nothing insane. Chronic kidney disease means that all the hormones and all the enzymes that work with the kidney are no longer going to be able to function at all. And that really sucks, right? Because then you're going to think, why isn't this working? Why isn't that working? And it's all really just that it's all working, but the main organ that's supposed to carry out the job is not going to be able to. So for this question, erythropoietin won't work, right? And that's very important for our kidneys. So erythropoietin won't work, so hematocrit should be decreased, bring you down to ENF. PTH secretion will be normal, so you're making parathyroid gland in this patient, but the PTH will not be able to act on the kidney to do its job of trashing away phosphate and retaining calcium. So serum parathyroid hormone will be increased. Your parathyroid glands are going to make more PTH as a negative feedback, right? They're going to see that the feedback is not coming. PTH is apparently not doing its job, so you're going to try to make more PTH. And at that point, you can just lock in as choice E, you're done. Serum calcitriol, which is basically your vitamin D, would be decreased. Vitamin D would be decreased. And the reason for that would be your renal 1-alpha hydroxylase enzyme will not be able to do its job, right? So 125 dihydroxy vitamin D will be low. You'll be stuck with just the 25 hydroxy vitamin D, but you won't get the 125 because 1-alpha hydroxylase is the one that puts the 1 there. Right, so that's going to suck, and that's basically all this question is about. Nothing insane, but this, again, I remember when I first started for step 1, when I was still new to all this, that questions like this could also come off intimidating. So getting to that level of confidence just takes time and practice and a true understanding of what is actually happening with these patients. And chronic kidney disease is also an extremely high yield topic in real life and in exams. This question was a pretty easy one, but I can see how it could be confusing. An experimental study is conducted to examine the function of POMC, pro-opiomelanocortin gene. The gene is found to encode an mRNA from which protein products are generated. This protein serves as the precursor of adrenocorticotropic hormone, ACTH, as well as beta-lipotropin. And the one they're not mentioning is MSH, right? Which of the following processes is necessary in order to generate these hormones, right? So one gene, multiple hormones, you can immediately think of that and then go like, oh, that must be alternative splicing, and then you get it wrong, right? That's the pit they want you to fall into, and that would just basically be them poking at the fact that your understanding of alternative splicing and genetics in general wasn't that strong enough. Alternative splicing is when you have an mRNA made from a gene, and then when you take the exons, you can rearrange the exons in different ways, and that's what alternative splicing is, right? After removing the intervening introns. That's not what's happening here. This is one gene making one protein that then separates into 3 different proteins, 3 different hormones, okay? And that is post-translational modification. The protein is already made, right? They actually spelled it out for you in the question. So they tell you that the gene is found to encode mRNA. That mRNA then makes protein, and it makes multiple proteins, right? The protein it makes one protein, and that one protein serves as a precursor of multiple things. That's what they spelled out for you in the question. That is post-translational modification. Right? This is also not, the plural cistronic or cistronic gene or whatever that you see in E. coli. It's not that either. It's not that you're making multiple genes that are making multiple products in one mRNA. No, it's one mRNA that made one protein, and then that protein got broken up into 3 different proteins. Completely different kind of thing. That's post-translational modification. If you picked post-transcriptional modification, well, post-transcriptional modification is alternative splicing. That's what happens. After you do transcription, you get an mRNA, you take out the introns, and then you make alternative splicing occur. That is post-transcriptional modification. Anything that happens in between transcription and translation is all post-transcriptional modification. Then you finally do translation, you make the protein. Now maybe you're going to add things to it to make the protein bend in a different way. That's also post-translational modification, right? So very important to understand those tiny little differences. Number 12 here, 24-year-old man receives an injection of histamine in the brachial artery. Which of the following changes is most likely to occur in his forearm in response to the histamine? So I wanted to revise something that I always tell people to keep looking at every day they study until it's like drilled into their mind. And this one I definitely had to revise because this is part of the group that's the hardest to memorize. Right, so signaling pathways of endocrine hormones is one of the pages I've told people, you got to have this printed out, you got to look at it every day, you got to make sure you memorize it, and you should be able to talk about all the hormones that are here as part of your endocrine review, right? So memorizing this stuff takes time, but it's very important because of course you can get silly questions like even UWorld has had where they give you these diagrams that I have at the bottom here, right? You can get questions where the answer is not going to be the hormone directly, but rather they're going to say, oh, it's a hormone that works using an intracellular receptor, or it's a hormone that works with the receptor tyrosine kinase, or a non-receptor tyrosine kinase. How would you memorize that, right? What pathway does he use? Does he use the MAP kinase pathway or JAK-STAT pathway, etc., etc.? Takes time, but totally memorizable. Like, I've got it down. I've looked at it so many times. I have it perfectly memorized. The hardest one to memorize is the IP3 stuff because all the hormones here are irrelevant or repeated, and they're not really part of the same system, so it's not really easy to memorize. Goat tag doesn't do the job because you have multiple G's and A's in here, and there's other A's in other places, so you're just gonna mix it all up, right? So these hormones don't really have a characteristic that makes them group together. So our question is about histamine using H1 receptors via IP3 and GQ. And what does histamine cause in that pathway? Vasodilation. The other histamine is your dinner for two, H2 receptor, which uses cyclic AMP and GS for acid release, right? That's a whole different thing. Do not mix up those medications either, right? The H2 blockers like cimetidine, all of these, they end in dine, D-I-N-E, for dining dinner with two people, right? The H1 antagonists are your medications that are, I believe, in the end of respiratory pharmacology, right? So those medications are the ones that are related to the vasodilation stuff. Now, being a vasodilator, if you can just remember the histamine is a vasodilator, you can knock out all the answer choices and just go with the one that says increased flow, right? You're not going to have decreased capillary filtration rate. If you have vasodilation occurring, there's going to be more filtration. You're not going to have decreased interstitial hydrostatic or oncotic pressure. You're not going to have a decrease in any kind of pressure because you're causing vasodilation. So the pressure, it should be pretty much unaffected, or pressure should be better, right? You should have a lower pressure, but not decreased interstitial hydrostatic or oncotic pressure. These are different things. These are irrelevant to the pressure that occurs with the vasodilation. Increased arterial resistance was definitely wrong. That's the opposite of what a vasodilator causes. So you just pick E and you move on. A lot of people were confused between B and C, right? But keep in mind that these things related to interstitial hydrostatic pressure, interstitial oncotic pressure, those are not really things you can alter per se using a vasodilator, right? So you'll never see someone fixing that using a vasodilator, and that's something you want to make sure you keep in mind. Superqual is saying, if H1 is a GQ receptor, shouldn't it cause vasoconstriction? And yes, gastrin you can remember as gastric. That's actually pretty smart. That's smart. No, GQ, if we go back to our autonomic drugs right here. Right, so H1 and H2. Oh, I'm sorry, did I put the wrong thing? No, I did. Yeah, we're talking about H1, right? H1 uses GQ. Yeah, right, GQ, and then it causes this to occur. And although most other things, right, would cause this kind of smooth muscle contraction, the H1 does not. H1, histamine itself does not. Histamine uses H1 receptors to cause vasodilation. Okay, so very important thing to remember. Although this is interesting that you mentioned that, because I see where you're coming from. By causing smooth muscle contraction, it would cause vasoconstriction, but that's not what's happening, right? So that's pretty weird. That's a good point you make. I'm definitely going to make sure I check that just to see, because I mean, I'm going to check what's up with that, not that whether or not this is correct. This is definitely correct because it's in the book, right? So they say it right here. Histamine H1 receptor uses IP3. IP3 is a GQ thing. Right? So IP3 itself is very significant, but histamine causes vasodilation. dilation. So oftentimes different receptors in different places have different responses. I don't know if there are H1 receptors anywhere that could lead to vasoconstriction, but I'll make sure I look this up again just to see if there's any other knowledge that I'm missing here. Right, but this question totally feasible, nothing crazy about it. Number 13, a 24-year-old woman at 28 weeks gestation is brought to the emergency department because of a 3-hour history of shortness of breath. She has asthma, but she currently takes no medications. Pulse is high, respiration is at 32, blood pressure is normal. Physical exam shows the use of accessory muscles of respiration, so she's definitely having trouble breathing. Diffuse inspiratory and expiratory wheezes are heard. An inhaled beta-2 adrenergic agonist is administered. What would you find as a side effect? Now you look at all the answer choices and you freak out if you don't know what beta-2 does, if you don't remember these asthma drugs, if you don't understand the differences between what are muscarinic side effects and what are non-muscarinic side effects, right? So that's where your knowledge is lacking if this question was a little difficult for you. Other than that, you can immediately knock out diaphoresis and dry mouth because those are muscarinic things. So that's not going to be relevant to an adrenergic thing. Then you have bradycardia and tremor, but you remember that beta-2 is related to the lung, right? You have 2 lungs. Beta-1 was the one related to the heart. Beta-2 also does some vasodilation, but it would never really cause brady or tachycardia per se, right? So that's definitely wrong. And if it would cause something, it would probably cause tachycardia, but not bradycardia. So then you're down to tremor and pallor. Pallor is just a side effect of anemia. You don't have enough blood. Pallor could be a side effect of vasoconstriction if you're not bringing blood to a certain part. But tremor is actually directly coming from the book. So if you don't remember seeing it in the book, that's one of the things that occur with passive reading. Right? So I always talk about active reading versus passive reading. Passive reading is when you read something and then you don't stop and think about it. You don't stop and revise it in your head. You don't try to stop and revise it without the book in front of you. And those are very important parts of active reading. Right? Another form of active reading is reading something and then writing it as you're reading it. So right here in the book itself, it tells you beta-2 agonists like albuterol can be given. It can cause tremor or arrhythmia. That's it. Right? So straight up from the book, nothing insane in that question. 14 was a test on your understanding of renal things, nephrotic versus nephritic syndromes. 4-year-old boy, which immediately, any renal question starting with a 4-year-old boy is either about minimal change disease or post-streptococcal glomerulonephritis. Very straightforward, right? That's the most common thing you get tested on for a 4-year-old boy in a renal question. 4-year-old boy is brought to the emergency department by his mother 6 hours after she noticed that his urine was red. He's otherwise feeling well. 15 days ago, the patient had a sore throat, fever, and cough, which is like now spelling out PSGN, post-streptococcal glomerulonephritis. His mother thought he had the flu and treated him symptomatically with rest and analgesics, and his status improved until now. His temperature is very high, pulse is 110, respiration is 22, blood pressure is 100. Physical exam shows normal breath and cardiac sounds, no organomegaly, and 1+ lower extremity edema bilaterally. So kudos to her mom for not running for antibiotics as soon as her child was sick. Right? She let the bacteria kind of run its course, and it's not the most fatal thing, but with strep, of course, later on, leading to rheumatic fever as a possible side effect and stuff like that, you definitely want to treat it as fast as you can. But she gave the child some time. Whatever. You look at the serum stuff, you look at your urine stuff, okay, but you get the picture. You get it. This is definitely a PSGN. You look at your answer choices, and they don't have PSGN. So now you freak out a little. No problem. You look at what is there anyway. This is not minimal change disease. There would be nothing wrong. This is why it's called minimal change disease. Nothing would be wrong. Membranous nephropathy is a nephrotic thing, right? So nephrotic things would only have proteinuria, not red blood cells in the urine. So you cancel out that. So A and B are not correct at all. Then you have papillary necrosis and tubular interstitial nephritis, which is AIN, acute interstitial nephritis. Those two answer choices are only here because they told you that the mother tried treating the baby with analgesics, right? Analgesics, NSAIDs, those things can eventually cause tubular interstitial nephritis, most commonly, or papillary necrosis. But keep in mind, papillary necrosis is a necrosis in the papilla, not in the glomeruli. It's not a glomerular problem, so you wouldn't really have red blood cell cast or red blood cell in the urine. In papillary necrosis, you actually get clots of blood in the urine, which is really, scary. And that's a very important page to revise, right? So you should have that page down, mastered very well. You want to know your AIN, acute interstitial nephritis. Make sure you know where to figure it out from, like, you know, what in the question gives it away. I have two really good practice questions right here that help you bring to home what is wrong in such a patient. How do you diagnose AIN? I also added extra notes from UWorld that kind of help you understand the IgE mediated part and the type 4 hypersensitivity part of AIN. Then you have ATN, which has a lot to do with your the BUN levels, right? So again, that's going to be given to you in a question. If it's given to you, you have to figure out what's happening using that. And then RPN, right? Diffuse cortical necrosis is a whole different thing, usually related to DIC. That's when you pick it. But RPN, right? This is just a papillary thing. You might actually have a gross hematuria, right? Actual blood clots in your pee, in your urine. And both of those, AIN and RPN, are related to analgesics and some other medications, acute pyelonephritis, sickle cell, etc. You know, I've seen sickle cell questions that are for RPN. I think even this one is a sickle cell question for RPN. Right, so I have a bunch of practice questions throughout my annotated book, which is why it's the book that everyone messages me to buy it, because it's very helpful to use to really seal the deal with what's happening in a disease and understand what's happening and how it will present, right? So our patient doesn't have any of that. These are not really things that really occur to young kids anyway. The AIN and the RPN, those are not really often things that occur in young kids, and it would not have anything to do with the sore throat. The sore throat, the potential strep infection this kid has had, was a giveaway for PSGN. They would have been too nice to you if answer choice D actually said PSGN. But proliferative glomerulonephritis is the same kind of thing, right? So it is still a glomerulonephritis. So you pick it and you move on, simply because the other answer choices do not make any sense, right? So proliferative glomerulonephritis is basically, let me show you right here. So these are all your nephrotic syndromes, and you go to nephritic, and you have rapidly progressive glomerulonephritis, right? And diffuse proliferative glomerulonephritis. And these are all different kinds of things. Membranous proliferative glomerulonephritis. Point is that post-streptococcal glomerulonephritis, which is the first one here, is also a type of progressive glomerulonephritis. These are all progressive glomerulonephritises. The book I'm using is actually First Aid 2019, but I've moved everything from First Aid 2020 into it, right? So for all the people that bought it, like this is a diagram from First Aid 2020. I moved it into my First Aid 2019. So, and then Super Koala did not know that nephritic syndrome can present with normal blood pressure. Yeah, definitely, nephritic syndrome can present with normal blood pressure. Right? Any nephritic syndrome can, because nephritic syndrome simply means something's wrong in the glomeruli. But renin is still working, angiotensin is still working, all of that is working. The kidney as a whole is still working. Something is just wrong in the glomeruli. So nephritic syndrome doesn't necessarily mean that there has to be a blood pressure problem. 15 was a cool question. So I got this right by process of elimination. A 3-pound, 9-ounce male newborn is delivered to a 16-year-old woman at 28 weeks gestation. So there's all kinds of things that are wrong in this question, right? We have a 16-year-old woman giving birth, and the gestation came out too early. So this is premature birth in a sense, almost. Not premature, but, you know, sort of premature, yeah. He develops severe respiratory distress within 1 hour and is treated with intubation and 100% inspired oxygen with continuous PEEP, positive end expiratory pressure. A month later, a chest x-ray shows persistently increased densities in all lung fields. So now that we're going a month later, that means that the treatment worked and the baby made it. However, now he develops pneumonia and dies anyway. At autopsy, the lungs are firm and poorly aerated. Microscopic exam of lung tissue shows prominent interstitial fibrosis surrounding irregular dilated air spaces with bronchiolar metaplasia. And they're really trying their best to confuse you and intimidate you and show you things in the question that would really throw you off. But there's no reason to. This is clearly NRDS, neonatal respiratory distress syndrome, and you have to remember the rib mnemonic for 3 different things that can occur as a consequence of using 100% inspired oxygen for treating this, right? And I'm sure you've all seen, if you've done UWorld questions, you've all seen questions that are relevant to some of those, like the retinopathy. So question 728 right here. Right? So neonatal respiratory distress syndrome, you treat it with maternal steroids before birth and exogenous surfactant for the infant. That's the actual worthwhile treatment to do. Therapeutic supplemental oxygen can result in retinopathy or prematurity, right? Which would be I think I have a URL question here. This one, the first one right here, right? Retinal findings. That's the retinopathy of prematurity. Intraventricular hemorrhage in the brain, ventricular hemorrhage, and then bronchopulmonary dysplasia. That's the rib, right? So our answer is right here. However, I won't lie, I actually couldn't remember bronchopulmonary dysplasia. I remembered the rib pneumonic, but I wasn't sure if that's what the B stood for. Now, looking at your other answer choices, this kid doesn't have bronchial asthma. This neonate doesn't have bronchial asthma. That's not what's presenting in this manner. Bronchiectasis and chronic bronchitis. First of all, the kid hasn't been alive long enough to have chronic anything. Okay, so it's not chronic bronchitis. And bronchiectasis and chronic bronchitis go together for COPD, which is definitely not what's happening here. Bronchiolitis obliterans, that's choice C, is actually the result of chronic lung transplant rejection. Right, that's one of the key words for that. So the only thing left after that was your bronchiectasis is also relevant to COPD stuff, so that's not going to work either. Only thing left was as choice D and F, bronchopulmonary dysplasia or cystic adenomatoid malformation. What is that, right? So our kid has the bronchopulmonary dysplasia. The other thing, I'm talking about it right there, right? So choice F is something you've probably never seen. It's basically where one of the lobes forms a cyst and can no longer function as normal tissue. And you can see here on the left I have an x-ray that shows the left lung has some cystic changes. On the right I have an CT or MRI. CT showing you that there's some kind of cystic thing in one of the lungs, right? That's what cystic adenomatoid malformation is. So if you do ever end up seeing it, that's what that would be about. NBME is pretty notorious for bringing up stuff like that in a question later on. So like, you know how they mentioned it in this question, in the next question, or in the next NBME, that might actually be the correct answer, cystic adenomatoid malformation. So worth knowing. This was also not bad at all. Very straightforward, very easy question, very nice diagram. The 35-year-old woman indicated by the arrow has a family history of retinitis pigmentosa. If you remember retinitis pigmentosa, then you get this correct. If you don't remember it, then you still get it correct by analyzing the data. They're asking you which of the following modes of inheritance can be eliminated based on this degree, right? Which of these can be eliminated? So you look at let me show you retinitis pigmentosa. So this is page 59. Alright, so retinitis pigmentosa is, where is it? Oh, I don't see it here. But wait, I just made this explanation a while ago, so I think I was thinking of something else when I wrote this. The answer is D for this. It is X-linked recessive, and you can knock that out. What's happening here, and you can see it in the diagram. So let me actually just delete that real quick. But this part is correct. It is D, and it is from that page. So what you can see in this diagram here is that all the men have it, and none of the women have it, right? None of the women have it. And when none of the women have something, that's always a giveaway. Somehow, only the men are getting it, right? Even starting from here, only the men are getting it, right? And every single man has it. None of the women have it. That is a sign of X-linked recessive, okay? Because women, it's a sign of eliminating X-linked recessive. You can knock that out. This disease, let me just confirm real quick from my answer key right here. I might have actually been thinking of the wrong thing, so I don't want to. Yeah, X-linked recessive you can knock out. Okay. Because the reason you can knock out X-linked recessive, right, is this guy has it, and then this guy has it. The only way this guy could give it to him would have to be something not related to the X chromosome. It cannot be related to the X chromosome, because men give their Y chromosome to all their sons, right? So let me grab my pencil here. Right, so this man gave it to this son and gave it to this son. That means that this man gave it on maybe the Y chromosome, or it's related to some other mechanism of transfer, right? Some other mechanism of inheritance. Definitely cannot be X-linked recessive. So you can eliminate, and that's what they wanted to know. How do you, which one of these answers can you eliminate? Definitely not X-linked recessive, and that's what's happening here. Okay, so when I was done answering this question, I was trying to come up with other things, and that was actually what was written previously. But let me just type that in real quick. Men pass their Y chromosome to sons, so there definitely is not X-linked inheritance here, since all men are having it. Right, so that's what's happening there, and that's all this question was about. Now, questions like this are a pretty high yield topic for NBME. They love bringing up random family trees like this and then asking you some kind of genetics question. So be ready with that. It's totally worth understanding everything that's happening here. One of the most commonly tested things on this page is the 2/3 probability in autosomal recessive. Autosomal recessive is the most high yield topic on step 1 because it's related to enzymes, it's related to all the different metabolism problems that we're going to be studying. And this 2/3 thing is often a topic that's very difficult for many people to understand, especially when calculating genetics questions, right? And then you have to use the 2/3 multiplication in there. Messes up a lot of people. So make sure you revise all your genetics questions on AMBOSS or UWorld the best you can and catch that. Understand autosomal recessive the best you can. Number 17 here. 35-year-old man comes to the physician because of a 1-week history of severe daily headaches of sudden onset. The pain is often located around his left eye and is associated with excessive tearing and redness of the eye. The rest of this question goes on to tell you other things that are supposed to throw you off. So headaches last from 30 minutes to 2 hours. Similar episodes occurred 7 years ago, often with periods of 1 year during which no headaches occur. Vital signs are normal. Fundoscopic exam is normal because he doesn't have any kind of fundoscopic problem. Nothing's wrong in the brain or eyes. Neurologic examination shows no focal findings, right? Nothing's wrong in the brain. Which of the following is the most likely diagnosis? So it's not a tumor or anything, right? And you look at your answer choices and you see cluster headache, and that's exactly what this question is spelling out. This is iconic, classic cluster headache. The giveaway things were the location of the headache, right? It's behind or around one eye. The onset and timing of the headache, so it's sudden onset and lasts for about 2 hours. And then the other thing, lacrimation, right? The tearing up, very important giveaway for cluster headaches. All the other answer choices here are completely irrelevant. 18, this is a cool question. So a 3-year-old boy is brought to the emergency department because of epigastric pain and bile-stained vomitus, so bilious vomiting. The child had been well prior to the episode and has reached all milestones normally. Which of the following developmental abnormalities is most likely to be the cause of this patient's problem? So the only way you can get bilious vomiting is if there's an obstruction past the second part of the duodenum. That's where the bile actually enters all the food that's been passing, right? So if you have any of these other answer choices like esophageal atresia, bile has not been added yet, extrahepatic biliary atresia, if you have biliary atresia, bile would not be coming in, no biliary tree. And then hypertrophic pyloric stenosis, that's still in the stomach, so there's no bile that's been added yet, right? Annular pancreas is one of the things that can cause bilious vomiting, but it doesn't mean that annular pancreas will always have bilious vomiting. Very careful with that, right? So if we go back and look at annular pancreas, I have a question on the same page right here from AMBOSS where they tell you in the question that there's non-bilious vomiting. And the reason for that is because where the annular pancreas occurs is not a solid thing. It can occur right above the second part of the duodenum, where that means that the bile would be added later on, and whatever vomit comes back would not have any bile in it, right? No bile in it. So very important to understand that annular pancreas doesn't always need to have bilious vomiting, but it can. Okay, so very important to make sure you get that difference. Other than that, bilious vomiting occurs anytime food comes back once it's been past the second part of the duodenum. This was a doable question even if you don't necessarily know what the diagnosis is. So 7-year-old boy has metabolic acidosis and persistent phosphate urea. This patient most likely has a primary defect of which of the following labeled sites in the drawing of the nephrons shown. So I like the picture because it's an ideal picture of how a nephron's supposed to be, right? I hate when they draw the nephron in the wrong way where the glomerulus is facing this way, right? That's wrong. That's not how it actually looks like. So this image kind of helps you understand why certain parts here are able to communicate with each other, right? What this question has told us is that there's metabolic acidosis and phosphate urea. So phosphates are mainly absorbed right here in the PCT, along with many other things. So many things are absorbed in the PCT. Phosphates are not really directly related to many of these other parts of the nephron, so you can just pick B and move on if you're not really sure what's happening. What is happening is that this is Fanconi. Right, so Fanconi is, let's go back and look at it, is the only one of all of those, Barter and Gittleman, is the only one that causes metabolic acidosis. And it's obviously because you lose the ability to reabsorb HCO3 in the PCT, right? So the question gave you two things, not just the fact that there's phosphate urea, but you're also losing bicarb, which is why the patient had metabolic acidosis. And you see how this picture is? This is the wrong way to draw a nephron, so I don't like when they do this. But yes, Fanconi syndrome. PCT issue, you lose bicarb, you lose phosphate, you lose all the other things that the PCT absorbs, and you get metabolic acidosis. Now, this is different from what occurs later on with the renal tubular acidosis, right? Those are all different things. Do not confuse the two. Renal tubular acidosis problems are renal tubular acidosis. That does not mean that it causes metabolic acidosis. These guys actually don't really tend to cause some kind of specific metabolic acidosis. For the most part, they're going to cause many other issues that can eventually lead to metabolic acidosis. So like, for example, this one. This is another thing you could have thought was the answer, and you would still get the question correct because this is a PCT thing. Right? So this one has metabolic acidosis in it, simply because, again, it's a PCT thing. You lose the bicarb, and it's also related to Fanconi, so it's pretty much the same exact answer choice. If anything, you're picking PCT, right? And that's what you really want to make sure you grasp. This one was, I felt like a slightly unfair question, but doable. 65-year-old woman comes to the physician because of blood in her urine with no pain for 5 days. Physical exam shows no abnormalities. Cystoscopy depicts multiple lesions as seen in the photomicrograph. So the lesion they're talking about is pretty much right here. Right, so this is your transitional cells of the bladder, and right here you have a problem. Which of the following is the strongest predisposing risk factor for the development? The strongest predisposing factor and the most likely correct answer was cigarette smoking. The other thing that can cause bladder cancer is schistosomiasis, right? But there was no major reason for you to pick that. It's not the strongest, most likely, etc., etc. They didn't give you anything in the question for you to pick schistosoma, so that's about it. Page 236 right here actually lists out all the different carcinogens. That's page 226 of First Aid 2019. You want to make sure that you know these associations. It would really help. So our patient has transitional cell carcinoma in the bladder. That comes from cigarette smoking. Right? Other things, you can see the other body parts, all these other different parts. You have the bladder here too for transitional cell carcinoma, but they didn't put these as choices. Textile industry. They tried by putting vinyl chloride, but vinyl chloride is with a V, vinyl for liver, right? Vinyl chloride right here. PVC pipes, liver, angiosarcoma. Right, so that's it for that. This was a pretty straightforward chemotoxman question about doxorubicin. So after completing 6 courses of chemotherapy for cancer of the breast, a 45-year-old woman has shortness of breath, dyspnea on exertion, and orthopnea. Vascular crackles are heard bilaterally, and there is an S3 gallop. X-rays of the chest show an enlarged heart, bilateral interstitial alveolar edema, and bilateral pleural effusions. Which of the following is the chemotherapeutic drug most likely to have caused these findings? Right. So they put bleomycin first because some people could fall for it. Bleomycin is relevant also, but that's not what's happening to our patient. Right. So it really depends on what you saw in the question. Because bleomycin, I like to remember as bleomycin blows the lungs. It also blows the balls because it's used for testicular cancer and can cause pulmonary fibrosis. If in this question all you saw were pulmonary problems, then you would think bleomycin. But what's actually wrong with this patient is the cardiac problems, S3 gallop. There's a gallop occurring at S3 because there's too much volume in the heart. Right? Too much volume in the heart, and that's occurring because of doxorubicin, which would be the dilated cardiomyopathy. The ABCCDs, the D is for doxorubicin, causing dilated cardiomyopathy. The only way to avoid that is to give concomitant dexrazoxane. Right, dexrazoxane helps, and they tell you right here. Right, dexrazoxane is an iron chelating agent used to prevent the cardiotoxicity. I'm so ready to eat. Ambitious young man, you guys are too nice. Thank you, I appreciate it. You guys are way too nice. How much more time till I get to eat? A little over an hour. Okay. So that's really all this was about. Right. Make sure you know what the other ones are, like vincristine and vinblastine. Right. Vincristine crisps the nerves. Right. Vinblastine blasts your bone marrow. So there's a bunch of mnemonics for memorizing those guys. I think it's right here somewhere. Vincristine, vinblastine. Right here, right? Vincristine, vinblastine. Vincristine crisps the nerves, so you get neurotoxicity. Vinblastine blasts the bone marrow, so you get bone marrow suppression. Paclitaxel, remember, taxes stabilize the society, so taxanes actually stabilize your polymerized microtubules in the M phase. So anaphase cannot occur, which means that you would stabilize things in metaphase, right? Remember PMAT, M-A-T. So metaphase, anaphase, telophase. Very easy to remember all of that for sure, and very easy to get questions on all of that as well. Number 22 was a question about VSD. So this is a really nice question. 10-year-old girl with a lifelong history of intermittent dyspnea is brought to the physician for a follow-up exam. During an episode of dyspnea, she turns blue, right? So this is cyanosis. The episode resolves after she squats. So something's wrong in the right heart. A systolic murmur was heard at birth. So that's also helping. It's a systolic murmur. Today, she also has a very strong systolic murmur heard at the pulmonic area, radiating widely to the back and the left side. Cardiac catheterization shows you all these pressures and oxygen saturations, right? And you need to know what the normal things are. You need to have it down, memorized perfectly. What are normal cardiac catheterization pressures and oxygen saturations? What is the most likely in this patient? Now, this patient is having later cyanosis, not early cyanosis. She didn't have cyanosis as an infant. She has cyanosis as a 10-year-old girl. So that comes down to your VSD, ASD, you know, those 3-letter things. And then squatting is helping. So let's go back to cardiology and take a look at what I want to talk about. So there's a mnemonic I made up, which is vape later, right? This one, vape later. So vape later is an excellent mnemonic because it helps you remember all the things that are generally going to occur in the question. The later is to remind you it's later cyanosis. Later also reminds you there's left to right shunting of blood. And vape reminds you of all the things. VSD, ASD, patent ductus arteriosus, the PDA, and Eisenmenger syndrome. It also is in order of what's most common. So V is the most common, VSDs. ASD are second most common. And since A is the second letter, that reminds you that the secundum type of ASD, the secundum type, ostium secundum defects, are the most common kind of ASD. Great way to memorize all of that. Now, why did squatting help? So when you squat, you basically squeeze the veins of your legs. The muscles of your legs are squeezing those veins. More blood comes back to the right heart. When you have more pressure and more blood in the right heart, now, remember in VSD, the problem is, let me draw this out real quick. Right, so let's just draw a basic heart with the 4 chambers. Right, so you have your left atrium, right atrium here. Right, left atrium, left ventricle, right ventricle. Okay, so if you have a VSD, you have some kind of opening here. So what happens is, when blood comes from the left atrium into the left ventricle, that's okay, that's your diastole. Then you do systole. Now, instead of sending the blood from the left ventricle into the aorta, where the pressure is super high, you'll instead send blood from the left ventricle into the right ventricle, because it's easier, right? And if you keep doing that, you keep sending all your oxygenated blood from the left ventricle into the right ventricle, back into pulmonary circulation. That sucks, that's not good. You hear pulmonic area radiation because, of course, now what's happening? You already have blood coming from the right atrium to the right ventricle. Now you have left ventricle to the right ventricle. That's a lot of blood in your right ventricle. A lot of blood going through the pulmonic area, right? So you hear that murmur as well during systole. The only way to fix this is if you increase the pressures here, then again now the blood will actually go into the aorta rather than going into here, right? And that's all that's about. Nothing insane. So you want to make sure you spend some time to really grasp that concept, really understand how that's working, because those maneuvers, those little concepts get tested all the time. You didn't even really need this. So now you look at the answer choices. The only answer choice you could pick was a palpable right ventricular lift, which is such a weird terminology for whatever that is, but something's wrong with the right ventricle, and it will be palpable because it's going to have extra blood in there. You're not going to hear a diastolic murmur. The problem is not with diastole, the problem is with systole. They gave you that in the question. They told you you're going to hear a systolic murmur. You're not going to have an enlarged left ventricle. You maybe have an enlarged right ventricle, but not an enlarged left ventricle. That occurs in aortic stenosis, where the left ventricle tries to get more and more powerful so it can pump against the stenotic aortic valve. You're not going to have hypervascular lung fields. You're not going to have a pulsating aortic mass. Those things are also irrelevant to this 10-year-old girl's presentation. 23 was a very straightforward question about succinylcholine. 10-year-old girl is scheduled to undergo fixation of a right femoral fracture. A neuromuscular blocking agent is administered prior to insertion of an endotracheal tube. You need to make sure you master your neuromuscular blocking agents and all the different kinds of questions you get. Like there's a question about the train of four thing, right? Phase 1, phase 2, all those things. You want to make sure you understand it. Now, subsequently, she develops muscle rigidity and fever. That is malignant hyperthermia. That's it. Very straightforward stuff. Blood pressure is unstable. Which of the following drugs most likely caused it? It had to be succinylcholine. That's a 599. Succinylcholine is what caused it. Inhaled anesthetic that causes malignant hyperthermia. Right? You treat it with dantrolene. And I put the dantrolene image in that too. Right? So there's many things you get tested on over here. You got the dantrolene questions. You get questions on the neuromuscular monitoring with train of four stimulation. Right, so URL questions, I put them here. And then, of course, tissue distribution of all these neuro stuff. Neuropharmacology videos that I have are really good. Those videos I went in depth to talk about everything you'd possibly ever need to know for step 1. You can kick ass. Just make sure you spend your time and take notes and really listen to it. Alright, so that's it for that. 2 more questions and then we're done. 24. The graph shows expiratory pressure volume curves that compare a healthy adult with a patient who has a 9-month history of progressive shortness of breath. As soon as you read this pressure volume curve, you should have known what this is about. Okay? Pressure volume, clearly we're talking about the lungs, so pressure volume in the lung, that is a compliance graph, right? That's a compliance graph. Very important. My respiratory videos, I went really in depth to talk about all the different curves and what's happening. Only in depth enough to master what's happening for step 1. Nothing too insane. And I taught you guys, more about, like, you see this graph? This graph is doing the same kind of thing. This is the weird curving that's occurring. It's related to compliance. Right? Compliance is a very high yield topic that always gets tested. Always gets tested. Volume and pressure come together to give you compliance, and you have to make sure you understand how that compliance factor plays a role, because even in the beginning of respiratory physiology, there are, let me see where that happens. Actually, it's in the path where they ask you about, these graphs, right, pressure volume graphs and whatnot. You want to make sure you understand how the compliance plays a role. So here, you can see this is volume and this is pressure, so this is a graph of compliance. You have normal compliance and you have decreased compliance. And the only answer choice that has decreased compliance is pulmonary fibrosis. Asthma and bronchopneumonia are irrelevant. Chronic bronchitis and emphysema are related to COPD, where compliance is actually a little higher than normal. Right? Air is stuck inside the lungs, so those answer choices you would cancel out too, and that's all this question is about. Last one for today, SIADH question, which was also very straightforward and easy. A thin 66-year-old man is brought to the emergency department because of confusion. Initial lab tests show severe hyponatremia, so salt wasting. The syndrome of inappropriate ADH secretion is suspected. Which of the following findings best support this diagnosis? So you look at all your answer choices, and none of them really should stick to you. So increase serum urea, nitrogen, and creatinine concentrations. I mean, the patient doesn't really have a renal problem, so no. Serum potassium concentration that's lower than 22.5. Urine sodium concentration less than 10. Neither of those really stick either. Urine specific gravity of 1.002. Maybe, you know, all of these things are possible depending on your level of understanding for this topic. All of these answer choices are possible, but one answer choice is for sure going to be true, which is C. Urine osmolality will be more than plasma osmolality. That is the definition of what ADH actually causes, right? Antidiuretic hormone means that you do not diurese, you do not lose water, so you retain water. When you retain water, osmolality is the same as saying solute concentration. So I rephrased it right here. I wrote that your urine solute concentration will be higher than your plasma solute concentration. There's going to be almost no water in your urine, so it's going to be 99% solute. So solute concentration is high in your urine. That means osmolality is very high in your urine. Your plasma osmolality is going to be very low because you're going to have a lot of water in your plasma, and all the solute is going to get diluted. Okay, that's it. Very straightforward stuff. Nothing crazy. Totally doable. Make sure you revise any of these topics when you're doing this revision. If SIADH is something you're not very confident with, you don't feel like you know everything about it, you can't recall everything about SIADH from the book, you know, if you can't recall that it's euvolemic, right, so 376, then you want to make sure each question you come back to the book and you revise it, right? Because remember also there's a Darrow-Yennett diagram that's associated with this, SIADH or compulsive water drinker, and you want to make sure you know all of this the best you can. Okay, so we'll stop here and then I'll continue on to the next half of block 2 tomorrow. Thank you very much for joining. Keep studying hard, and feel free to shoot me an email if you want to purchase any of these things, previous NBME explanations, the book, whatever it might be. See you guys tomorrow. Thank you.